It's pretty slick, actually. Got a new one in here that's movable. Okay. Chapter 23, we're going to be talking about your respiratory system, which actually fits in really nice. I mean, the people who make these books, they think about the way that they're putting them together. The respiratory system fits in really nicely with the cardiovascular system because they cooperate with one another. If your lungs were not functioning correctly, your heart could pump for all it's worth, but they wouldn't have any oxygen to pump around. And so your respiratory system, when you breathe into your lungs and you breathe out, you are bringing stuff into your body that you need, like oxygen, and you're getting rid of wastes like carbon dioxide. And so they work together. The one can't function without the other. It's obvious, like if you have a case of a drowning, right? Your heart was working just fine, but if your lungs can't do their job, then it's kind of a moot point. So we're going back to electron microscope pictures. This is a scanning electron microscope picture of one of the air sacs of the lungs, and you can see the simple squamous epithelium that we talked about way back in A&P1. So these are single little flat pancake-shaped cells, and they're arranged into little air sacs. And I remember learning for the first time myself that your lungs were not just like hollow balloons. Because when I was a little kid, you just kind of imagine you blow up a balloon and it's kind of like inflating your lungs. But your lungs are not hollow tissue. They're really spongy. And there's all those, if you imagine an actual sponge, all those little tiny holes in a sponge would be the air sacs of your lungs. There we go. So we're going to start out with a predict. There are flashing lights at 2 in the morning. And that's going to tell the neighbors that something's wrong with the Theron home. Mr. Theron, who has moderate emphysema, could not stop coughing, so his wife called 911. In the ER, a physician listened to Mr. Theron's respiratory sounds and concluded that his left lung had collapsed. And that's something that you hear often, especially after car accidents or other issues. They have collapsed lung. So kind of what are they talking about there? Explain how emphysema affected Mr. Theron's breathing, what caused his lung to collapse, and how the physician was able to detect the collapsed lung. So after we're going to revisit Mr. Theron at the end of the lecture, but keep him in mind and think about emphysema. We're going to talk a little bit about that and how it probably affected his lungs and how that's going to cause the symptoms that the doctors noticed and what they might be able to do about it. So, function. We always start out with functions. Functions of the respiratory system, there's 4 main ones that you need to worry about. If you think about the way that our tests are worded, often it's A through E, right? So if you have 4 main functions, you could pick out the one that's not one of the main functions of the respiratory system, right? Ventilation, basically moving air in and out of the lungs, and if you asked somebody who hasn't been through this class, what's the job of your lungs, that's probably the one that they would pick, right? But also, there's a difference between external respiration and internal respiration. And when I teach my high schoolers in biology, I start out the unit about the mitochondria, and I say, why do you need to breathe? And what do you think a 16-year-old would always tell me? Why do you need to breathe? To live, yes. And I say, well, why do you need to breathe to live? And then they get very mad at me because I won't tell them. They have to figure it out. But the reason why you need to breathe to live is that connection there between external respiration. So if you count your respiration rate, like how many breaths per minute, we're going to do that in lab today, that's your external respiration. That's something that you can hear with a stethoscope or just with your ears if it's a quiet room. It's something you can see when the person's chest is rising and falling. That's your external respiration. But then there's also that process of external respiration supports the process of internal respiration. So the reason why you need to breathe to live, like your lungs just need exercise so you can live, what are you trying to accomplish by breathing? Moving the blood. Moving the blood is your heart's job.
Getting oxygen to the rest of your body.
Yeah, so that's the way that oxygen gets into your body. And so by that external respiration allows the oxygen to get into your blood cells, and by getting oxygen into your blood cells, do your blood cells just keep it for themselves? No, where does that oxygen go? To tissues and organs. And then those tissues and organs actually use that oxygen in order to do the chemical reaction of breaking down sugars. Okay? So when you break down big molecules in your cells for energy, like sugars and fats and starches and things like that, that process of breaking down those big molecules relies on oxygen. In the same way, it's the same chemical equation as a bonfire in your campsite or your backyard. So the same way that you need oxygen to burn a piece of paper or a log, you need oxygen to burn the calories in your food. Only not with a flame, because that would be dangerous. Okay? So internal respiration is that gas exchange between the blood and the tissues. And so each and every one of the cells in your body needs a constant supply of oxygen to stay alive. And your lungs help support that by being the entry point of oxygen. Through the transport of oxygen and carbon dioxide in the blood, so this is how, that third one right there, that's how the respiratory system and the cardiovascular system are linked together. And they're side by side in your thoracic cavity. So the external respiration transports the oxygen and supports the internal respiration. Your lungs also get rid of carbon dioxide as a waste. So your functions here, by doing all of that, your respiratory system works with your cardiovascular system in order to be able to, number one, regulate the pH of your blood. So when you think about breathing, you don't think, oh gee, I'm helping the acid-base balance of my blood, but you are. Because by getting rid of carbon dioxide in your blood turns into an acid. So by getting rid of carbon dioxide, you're getting rid of acid in an indirect way. It also is able to produce chemical mediators called ACE, and we're going to talk about ACE a little bit more when we get to that point in the lecture. Speech. If you did not have lungs, if you didn't have your respiratory system, you wouldn't be able to force air past your vocal cords, and you wouldn't be able to communicate as effectively. And so being able to speak is one of the things that we rely on for our respiratory system. Smelling. You take a big breath in. Not only does it bring oxygen into your lungs, but it also brings those odor chemicals into the superior surface of your nose. And then protection. It does have an epithelial surface on the inside of the lungs and a mucus layer, so it protects you against microorganisms. It's one way that you're exposed to the outside world. And so there's a lot of protective layers built into the lungs as well, so you don't get pneumonia every day. Okay, we're going to get into the functions more later. Questions on any of those before we move on? Okay, some anatomy first. Your respiratory system is divided into an upper tract and a lower tract. Have you heard of somebody having an upper respiratory infection, or an upper respiratory tract infection, or a lower respiratory tract infection? Okay, so a typical cold that sits in your nose and your throat, and it has a cough that pretty much stays right in your throat area, it's drainage and stuff, that's going to be an upper respiratory tract infection. They're annoying, but usually not as dangerous. A lower respiratory tract infection is going to involve an infection actually down in your lungs, or the airways that lead into your lungs. Things like bronchitis are going to be a lower respiratory tract infection, or pneumonia is going to be an infection of the lower respiratory tract. So the nose, the pharynx, the part of the back of your mouth when you say ah, and these associated structures like the epiglottis and stuff, those are your upper respiratory tract. And then the lower tract is everything below the larynx and below. So the trachea down here is actually part of your lower respiratory tract. So basically upper is shared between respiratory and digestive system. Okay, you can kind of think of it that way. And where it's just your respiratory system, that's lower. So right here at the epiglottis, this is where your esophagus goes posterior and your trachea goes anterior. And so where those divide off, then it becomes lower respiratory system. Okay? So starting in the upper respiratory system, this is one of the models that I have that we're going to look at more closely in lab. But Obviously, your nose is part of your respiratory system. You can breathe in and out throughout your nose unless you have some sort of nasal infection. The nasal cavity starts out at the nares, so the opening to your nose. The fancy word you teach little kids is nostrils, but we're going to call them nares. Okay? All the way back to the choanae, which is right here. So that's your nose, the nasal cavity, from this opening to this opening. So this little canal, this passageway that leads to your pharynx, that's the choanae, right there. The vestibule is just inside the nares, so this big open area, like where you pick your nose, okay, that would be the vestibule where you shouldn't pick your nose. The hard palate is the floor of the nasal cavity, so you actually have bone there, separating your nasal cavity from your oral cavity. The nasal septum doesn't show up in this picture, but it's the partition that's dividing the cavity. It can be made of soft tissue or cartilage or bone, depending on how far back you go. So at the very, very back, that was part of what we labeled with the skeletal system, with the vomer bone and the perpendicular plate of the ethmoid. Sometimes people talk about having a deviated septum. When I was a teenager in the 90s, the movie Clueless was really popular, and the running joke in that movie is that girls would go, and they were from the fancy part of California, and girls would say that they had a deviated septum when really they just went and had a nose job because they'd come back with bandages on their nose. So having a deviated septum, having a septum that's off kilter or not shaped correctly can cause problems, and it's a reasonable reason for plastic surgery to fix that. But the running joke was that that's what people said it was, and it wasn't. The choanae are bony ridges on the side walls with meatuses in between. What's a meatus? Think about it, you know it. What else have you heard the word meatus?
External auditory canal.
Yes, external auditory meatus. So what's a meatus? A canal or a passageway, right? Very good. Those are openings into the paranasal sinuses and to the nasolacrimal duct. And so when you cry, we talked about when you cry you get a runny nose, or when you get an infection, when you get an upper respiratory infection, it can spread to your sinuses, and that's thanks to those meatuses. There's passageways that lead to all the little openings so that the infection can spread or your tears can make your nose run. The job of the nasal cavity is obviously a passageway for air, but with the mucus and the hairs that are inside of your nose, it also cleans the air. You know that if you've ever done some sort of dusty work, or if you've hung out in a city with a lot of smog and pollution, and you go to blow your nose, what color is that mucus? Black, right? So if you've been out in a dusty environment around a lot of soot, you can see how much yuck the mucus and the hairs in your nose will trap. So it also cleans the air. So we talked about your innate immune system, right? You're born with that. That's part of your defense against the outside world. It also humidifies and warms the air, and animals that live in very dry or very cold climates have actually specialized nasal passageways to try to retain some of that warmth so that when they breathe, it's when you breathe out, if you're cold, can you go like this and breathe out? We usually use our mouths, but you can use your nose too. So do that. You look ridiculous, but do it. I'm doing it. Is it warm?
Yeah.
Okay. So imagine if you lived in a cold climate, are you going to lose a lot of body heat just by breathing out? Yes. And so for people, we have like scarves and mufflers and things that we use. But for animals that live in cold climates, they have specialized nasal cavities so that they retain a lot of that heat. They have an extensive capillary network that will reclaim a lot of that heat before it goes out and gets wasted to the environment. Also, animals like camels will reclaim a lot of water. So if you would hold a mirror under your nose and breathe out, would it fog up? Okay. So camels wouldn't do that because they reclaim a lot of that moisture and don't let it out. It's one way that they preserve water. But as you breathe in, if the air is dry, it humidifies that air a little bit as you breathe in so that the air coming into your lungs isn't quite as dry and won't dry out your lungs. The nasal cavity is where your organs for smell are located. And along with the paranasal sinuses in your maxilla and your frontal bones, they're the resonating chambers for speech. And you can tell that, there's nothing wrong with my sinuses, but if you close your nose, and don't try to tell, you can increase your voice or increase the pitch of your voice and sound like Urkel, but just if you close your nose, your voice sounds different. And so your nose kind of provides that resonating chamber for sound to give your voice its specific quality. So the shape of your nasal cavity and the shape of your sinuses help your voice sound the way it does, so that when you call somebody on the phone, even without caller ID, you can tell that it's them. It's kind of a lost art anymore. You always know who's calling. But sometimes people call. I had a student call me out of the blue yesterday, 2 days ago, and I was focused on, it was a number I didn't recognize, and so I answered it. And I'm focused on this class and what I'm teaching now, and I answer it, and he said, "Hi, is this Mrs. Miller?" And I'm thinking, my brain is going through all the male voices in class, trying to figure out who it is. And he's like, "This is Zach." I was like, "Zach? No, Zach. Did I miss that in Zach in class?" No, it was a former high school student I hadn't heard from in like a year, and he was just found my number somewhere and was calling me, so we had a nice chat. But anyways, it allows you to, but I had to place his voice because just his name wasn't helping me. I was like, "Oh, Zach, hi." So your nasal passageway helps give your voice its distinct quality, so you can tell it from other people's. Okay, if you go posterior and inferior from the nasal cavity, so if you go back and down, you get to the pharynx, and you can tell from this bracket right here, you have the oropharynx and the nasopharynx, and the laryngopharynx. So there's 3 different sections. But it's the common real estate, basically, between the digestive system and the respiratory systems. So in the nasopharynx, that's up higher. The nasopharynx is right here. Generally, it's mostly the property of the nose, but this is your uvula right here. So you see when you swallow, the uvula flips up, and so this nasopharynx, you can get a little bit of food right there as you swallow and you push the food up and then back down. Okay, so it's a shared real estate. In the nasopharynx, mucus and other debris ends up being swallowed, or if you put nose drops in, or eye drops, you can end up tasting that, right? Because you end up swallowing that. Also in the nasopharynx are the openings for the eustachian tubes. The eustachian tubes are the auditory tubes. They link back up to the middle ear and allow you to equalize the air pressure in your middle ear and the outside world. So when you swallow or you yawn, it kind of stretches that opening to the eustachian tubes, and it allows you to equalize the air pressure in both areas. Just by mentioning yawning, people are going to yawn. That's an interesting psychology experiment. The floor of the nasopharynx is the soft palate, and the uvula is the back extension of the soft palate. So the uvula is just the end of your soft palate that kind of hangs down a little bit. The oropharynx right here is where you can either swallow or breathe. It's the back of your throat. When the doctor says, say, "ah," and you look at something, you're seeing the oropharynx. And then the laryngopharynx is down a little deeper, so you can see that it's right here. It's right at the opening to the trachea. And so when you swallow, we're going to do digestive system next, but when you swallow right here, there's those lingual tonsils. When you swallow, there's a little flap of cartilage right here called the epiglottis. And as you swallow, it should push this little flap down so that it closes off the opening to the trachea. That way you don't choke on your food. Okay? So this area right here is the laryngopharynx. That was all upper respiratory system. As soon as we get to the larynx, right here, we're entering into the lower respiratory system. So there's a lot of different views here. This is the front view, the back view, and the side view of a sagittal section. So this one is cut in half, so you can see what's going on inside. The larynx is what we would commonly call the voice box, and you can feel it vibrate if you put your hand on your throat while you talk. It contains your voice box, but it also contains a couple of other structures to help keep you from choking. And so one of the main goals for protection in the respiratory system, since we have a joint cavity for introducing food and air into our system, is we have to worry about choking. And so there's a couple of different flaps of cartilage. The epiglottis is one of them that helps try to protect us from food going down the wrong pipe, quote unquote. Let's see. There's some cartilage right here that the thyroid is attached to. We're going to do a little bit of anatomy on this in lab, but I just want you to know some of the major features. Here's the hyoid bone that we learned about back in the skeletal system. And then the epiglottis, you can barely see it from the front. You really have a better view of it in the back. Let's see. You can also see from this picture right here how the epiglottis can fold down and close this opening right here to the trachea. The vocal cords right here, you have the true vocal cords and the false vocal cords. The false vocal cords are more superior, and the true vocal cords are more inferior. They're below the other ones. They work together, but these are the ones that produce the primary portion of your voice. The vocal cords are below the epiglottis. They're right in the middle of your larynx. And then below, the vocal cords also help to prevent choking. They can vibrate and kick stuff out. Below the vocal cords, you start out with these cartilage rings that help keep your respiratory tract open. And it becomes the trachea. Questions on any of that? Okay, so the cartilage in the larynx can be divided up into paired and non-paired. The unpaired cartilages just have one big chunk, and they don't have like a corresponding left and right half. So the thyroid cartilage is the largest. In men, it's what you call the Adam's apple. So women have that too. They just don't get that surge of testosterone that makes it grow to a point where it's obvious. And so that thyroid cartilage is just one big chunk, so it doesn't have a left and a right. It's just one piece. The cricoid cartilage is the lowest one. It's at the base of the larynx. And then the epiglottis I've showed you a bunch of times in the pictures. That's the flap that covers up the opening to your trachea. The thyroid cartilage and the cricoid cartilage are hyaline cartilage, but the epiglottis is elastic cartilage, so it has a little bit different texture than the rest of the cartilage in your respiratory system. Then there's three sections of cartilage that are paired. That means there's a left and a right. So there's the arytenoids, which are attached to the cricoid, the corniculate, which is attached to the arytenoids, and the cutiform that's contained in a mucous membrane. I want you to be aware that they're there, but I'm not going to do those for labeling. Okay, there's paired and there's unpaired, so there's left and rights of these. Then the ligaments that extend from the arachnoids to the thyroid cartilage would be the true vocal cords and the false vocal cords. The false vocal cords are also called vestibular folds, and the true vocal cords are just called vocal folds. So there's vestibular folds or false vocal folds, or true vocal cords and vocal folds. So flip those around. But the true vocal cords are the ones that are involved in sound production, but you can see the false ones first if you would do a scope and look down somebody's throat. The opening between the true vocal cords is called the glottis, and there is a really interesting video of a woman singing, and you can see what her vocal cords look like. If you don't like having things shoved down your throat, this might gross you out. But that's like the name of this class, so. It's processing my request. I didn't say it was good singing. Well, she's got a thing shoved down her throat. See how it stretches out when it gets higher? This is the epiglottis right here. I just thought that was very interesting. I'm impressed that she can sing it all with a camera shoved down her throat, so.
That's what I was wondering.
Oh, you. There's longer versions of that available on YouTube if it just fascinates you like it does me. There's all kinds of learning time wasters that you can do.
Like higher pitched voices have like longer.
Yeah, so the low and the high pitched, it's a lot like a stringed instrument. And so the thicker and looser the string, the longer the string, the lower the pitch is going to be just in general. And then the shorter and thinner and tighter that it is, the higher it's going to be. And so it works a lot like a guitar. Only it's more like those two grass blades that you put between your thumbs and blow. but in a more controlled fashion. So think of it kind of like a clarinet in the way that it vibrates, but like a guitar in the way that it's strung. Does that make sense? Okay. Okay, so the jobs of your larynx is to maintain an open passageway for air movement. So with all that cartilage, it helps keep your trachea open so you can get the air in and out of your lungs. Even if you have something pressing down on your throat, it's pretty sturdy cartilage, so it'll work really hard to maintain that opening so that you're able to breathe. The main pieces of cartilage that are responsible for that are the thyroid and the cricoid cartilage. The epiglottis and the vestibular folds are going to prevent you from choking. They prevent swallowed material from going down, like I said, the quote-unquote wrong pipe, being you want your swallowed material to go down your esophagus and not your trachea. Sound production, obviously, we just watched that. The greater the amplitude of the vibration, the louder the sound. So when you yell, your vocal cords are vibrating, are making larger vibrations. The frequency of the vibration determines the pitch. And so if those vocal cords vibrate and they're vibrating slowly, that is a low pitch. They're vibrating more slowly. If you make a really high sound, like my daughter screaming, she's mad at somebody, it's very high pitch, or when she's excited, like it's her birthday today and she got some animals this morning, some little plastic ones, and she's like, ah! Glad we're not in the car. That is a higher frequency of vibration, so the vocal cords are vibrating more quickly, more times per minute, per second. The arytenoid cartilages and the skeletal muscles both together determine the length of the vocal folds, and they also bring the folds away from each other, abduct, remember, take away from the center. When you're not speaking, to pull them out of the way, making the glottis larger. And so it's a lot easier to breathe when you're not talking, because those vocal folds will separate from one another and create a larger opening. Within the larynx, there is pseudostratified ciliated columnar epithelium. Ooh, big words in a row, remember that? That's from like what, chapter 4, 5? Yeah. that traps debris. Remember the pseudostratified columnar epithelium has a lot of mucus-producing cells. It has a lot of those goblet cells. So there's tons of mucus there, so all the time, right? So between the mucus and the cilia, it traps and sweeps out debris that prevents it. So there's a protection function there, not just from choking, but from getting things into the lungs where they could cause an infection. So this is what we were looking at earlier. The lady on the video, hers was flipped around. So you saw these two little knotty things. This is the corniculate cartilage. That was on the top in the video. Remember that? And so this ridge right here is the epiglottis, and you saw that in the video pretty well. So you have the true vocal cords here, and then the false vocal cords are here and here. Both of those, if they get infected, can get swollen, and they won't vibrate properly, and that's when you lose your voice. Okay? So imagine if you did play clarinet or oboe, and then your reed was swollen, and it wouldn't fit on the instrument properly. Would you be able to make a sound come out of the instrument? Not very well. Okay. So this is the cartilage right here that can open and close those vocal cords. And you saw that in the video as well. Seeing it in action is really cool. We could do that in lab, but I'd have to shove a camera down your throat. I don't have one, plus you might not like it. I would choke. I can't imagine how she sang and didn't just choke. But I'm glad she did, because it was awesome to watch. If you go posterior to the larynx, then you are finally in the trachea, and you are solidly in that lower respiratory system. The trachea is a tube made of dense regular connective tissue and smooth muscle. So if it's smooth muscle, are you able to control it very much? Your trachea spasms, can you control that? Spasms in general you can't control. But smooth muscle is not under conscious control. There's also dense, regular connective tissue to help it hold its shape, because it is really important for your airway to remain open. The trachea is kept open also by a sequence of around 15 to 20 hyaline cartilage C-shaped rings. And so they are continuous around the front, but when they reach around to the back, they don't reach all the way. Kind of like your thyroid. Remember how your thyroid doesn't reach all the way around to the back? Well, those C-shaped rings don't reach all the way around to the back either. So on the back of your trachea, it's just that smooth muscle and the dense connective tissue. Those cartilage rings don't continue all the way around. Doesn't show very well on my model. If you've ever been lucky enough to dissect a heart and lung set of a cow or a pig, that's really obvious. It's called a pluck, when they just take the whole heart and lungs out. On the back side, there's an elastic ligament membrane and bundles of smooth muscle tissue, and that smooth muscle can constrict and kind of bring the size of the trachea. It can constrict the trachea or open up the trachea. The inner lining of the trachea has a mucus layer on it that traps debris and cilia that push it up towards the larynx and the pharynx. So you're still talking about pseudostratified columnar epithelium in the trachea. If you're looking through microscope slides and you want to try to find some pseudostratified columnar epithelium, trachea is one of the best places to look. Once it gets down to the level of the lungs, the trachea divides, and you can see it on my model a little bit right here, to form the left and right primary bronchi. Okay? So you have the left and the right, the patient's left and right. Right at that spot, right at my finger right there, where they split, there's a spot called the carina. And the carina has some really, really sensitive nerves in it that is kind of your last resort coughing reflex. It's really sensitive to irritants and things because you really don't want bad stuff going down into your lungs. So if something has made it past your epiglottis, past your vocal cords, past the mucus and the cilia of the trachea, and all the way down to this branch right here, you really want to be able to cough it out. before it gets actually into the tissue of your lungs. And so it's really, really sensitive to irritation and inhaled objects, and it's going to initiate your cough reflex. And that's your last chance to get things out before they get down into your lungs. Whether it's water or some other irritant like smoke or something like that, you just don't want it in your lungs.
So that's when it's getting to the coughing?
No, you should be coughing before that. Like even if you just get something stuck in the back of your throat, you have a cough reflex right there. But the carina down here, that section of cartilage has some nerves attached to it that are really, really sensitive to irritation. So it doesn't take much to make you cough. And so if you think about like breathing in a smoky environment, like if you're in a house fire or just too close to a campfire, I mean, that smoke isn't inhibiting your vocal cords, your epiglottis, and you're not swallowing, so that's not like a choking cough reflex. But when it gets down here into your lungs, that smoke irritates that chorea area and it makes you cough to try to help your cilia get those particles out. So it's really sensitive because the upper area usually stops the bigger stuff. Let's see. Here it is under the microscope and in a drawing. So under a microscope, you can see the trachea is more anterior and the esophagus is more posterior. The yellow stuff is the cartilage, that hyaline cartilage ring, and you can see how it doesn't continue all the way around to the back. And then the esophagus is more of a muscular tube that flattens out a little easier. I mean, when you swallow, you swallow. It doesn't have to constantly stay open. Let's see. This is a drawing and this is a microscope picture, so you can see these goblet cells that are producing all the mucus and the cilia. And then in the drawing here, you can see how the cilia can trap foreign objects, and they generally have an upward sweeping motion, and it sweeps that mucus up and out so you can cough out the bad stuff. So, what do you think would happen to the shape of the trachea when a person swallows a large mouthful of food? And why is this change of shape an advantage? So looking back up here, the esophagus can kind of collapse on itself when you're not swallowing. But what's going to happen to the shape of the trachea when you swallow a big old bite of food? So this is going to bulge, right? You have vertebrae right here, so that's not very flexible. And so it's going to bulge in right here, and it's going to decrease the size of the trachea. Why would that be an advantage when you are swallowing to decrease the size of your trachea? Yeah, it gives it, if you happen to swallow some down the wrong tube, it would prevent bad stuff from getting down your trachea. Okay. Okay, your bronchi. They're kind of like your arteries and veins in that the big ones are named, and the branching that they do is predictable and random at the same time. It's a fractal nature. And so you can get some predictableness. I mean, obviously you have the main or the primary bronchi, and then you have some predictable branches that go off to the lobes of your lungs, and so those can be named. But they always kind of branch off at a similar angle, which is what gives it that fractal nature. And when you get down to these little tiny ones, they don't have names anymore. They're just called terminal bronchioles. And they're not named individually because every person's pattern is going to be a little bit different. You remember how I passed around that picture of all the arteries in the head? Okay, at the body exhibit, they have similar displays, but it's all of the circulatory system of the lungs. And it's just as mind-boggling with how much blood vessels are in the lungs to help carry oxygen and stuff. So the trachea, your main pipe right here, your windpipe is what people are talking, when they're talking about the trachea. It divides into two primary bronchi, the left and the right. The primary bronchi divide into secondary bronchi, and then those divide into tertiary. Okay, so you have your trachea, and then the primary bronchi, the secondary bronchi, and the tertiary bronchi. Okay, primary, secondary, tertiary. They get smaller and smaller. The bronchopulmonary segments of your lungs are defined by those tertiary branches. So you can see right here, this is primary. The ones that branch off of that are secondary. So this would be secondary and this would be secondary because it branches right there. And then the tertiary bronchi come off of the secondary. So now on the labeling, I'm not going to say, ooh, this one right here, you've branched and then you've branched again, and then also is this one primary? I'm going to pick obvious ones, okay? You have primary, main branch would be secondary, and then the larger branches that you can still see here are tertiary. Does that make sense? So tertiary can be at a couple of different levels of branching. Good. Those tertiary branches lead to the lobes of the lungs. The tertiary bronchi divide even further into smaller and smaller bronchi, and then into bronchioles. You start calling them bronchioles when they're less than 1 millimeter in diameter. So when the little tiny tubes into your lungs are smaller than this size or smaller, then they are bronchioles. Okay, but they still have kind of they don't have the cartilage rings anymore, but they have a dense connective tissue structure that helps them stay open. Those bronchioles keep dividing out until they finally get into terminal bronchioles. Terminal bronchioles are a lot floppier. They don't have the dense tissue to help keep themselves open. You're getting more to the level of like air sacs and diffusion. There's going to be a network of cartilage that holds that tube system open, and then smooth muscle tissue that helps control the diameter of the tubes. And we talked about that a little bit when we talked about epinephrine and norepinephrine and how they affect asthma. And we talked about relaxing the smooth muscle in the bronchioles of the lungs. And so if somebody is having an asthma attack, the smooth muscle around the bronchioles in their lungs is constricting, and it's like trying to breathe through a coffee stirrer instead of a regular straw. It is making those tubes really small. And so if somebody's having an asthma attack, they need medicine to relax those smooth muscles so that those tubes can get bigger and they can allow the flow of air in and out of the lungs better. As the tubes become smaller and smaller, the amount of cartilage decreases, like I was saying earlier, and the amount of smooth muscle increases. So you kind of switch over from being controlled by cartilage to being controlled by smooth muscle the further you go down. After branching and branching and branching and branching and branching and branching, you finally get to the respiratory zone, which is the site of gas exchange. So this is where we actually do the work of the lungs, which is trading carbon dioxide for oxygen. The respiratory bronchioles branch off from the terminal bronchioles. They have very few alveoli up in here, and they give rise to alveolar ducts, which have more alveoli. So these little sacs right here, these are the air sacs of the lungs. This right here is an air sac, not a big open balloon, but a tiny little bubble. And if you would actually cut into some lung tissue, it looks like a very, very fine-grained sponge. Okay? So you have the terminal bronchiole, the respiratory bronchiole, which branches off and goes to alveolar ducts that end in an air sac. Each of these tiny little bubbles on the surface, that looks like it has a blister problem. One of them is called an alveolus. Together, all these little lumpy bumpy things are called alveoli. That's a plural. Okay? So one way that you can tell some of the difference, the terminal bronchioles still have a pretty extensive network of smooth muscle tissue wrapped around it. By the time that you get to respiratory bronchioles, you start to see a few alveoli. By the time that you get to the alveolar ducts, the smooth muscle pretty much is not continuous anymore. It's just a little bit here and there. There's no smooth muscle tissue around the air sacs. And the air sacs are made up of multiple alveoli. You get that level of organization there? Okay. Terminal respiratory duct sac. And the respiratory, or the ducts, or the sacs, you can have alveoli. But they're the most concentrated down at the very, very end. So you can have a little bit of gas exchange here, but most of it's going to happen down here. This is new, so I'm slowing down. Questions? This is where you have, this is going to be a branch of the pulmonary artery. Why is it blue on the drawing? Yes. Remember, the pulmonary arteries are the only ones, the only arteries that do not carry oxygenated blood. So this right here is blood that's coming right out of the heart. And it's going to come down here and branch off into a capillary bed, and right here around these air sacs of the lungs, this is where it's going to drop off carbon dioxide and pick up oxygen and become oxygenated. And it's going to feed back in. So this is opposite. You have to think in your mind that we're in the lungs here. Usually our capillary beds go from red to blue in the books. They're all red, remember that. But here we're going from blue to red because we're going from deoxygenated, we're picking up oxygen in the lungs, and then this is a pulmonary vein that is going to return that oxygenated blood back to which chamber of the heart? The left atrium, very good. Let's see. There are elastic fibers wrapped all around the alveoli of the lungs that help them return back to their original shape. So you have a pressure difference that helps inflate your lungs, but returning those little air sacs back to their original shape is helped out by these elastic fibers that are wrapped around the outside. The alveolar sac, at the end of one of these little branches right here, you tend to have about 2 or 3 little alveoli. That's pretty typical. So up around here in the duct, there's just going to be single alveoli, and down here in the sacs, they're going to terminally end in a branch that looks like a clover. You'll have between 2 and 3 little air sacs. There are, by the time you get down to this area right here, you're down to simple squamous epithelium and not the ciliated columnar epithelium. That gradually tapers off as you go from cartilage to smooth muscle around the outside of those branches. So gradually you kind of lose the pseudostratified columnar epithelium and it starts getting populated with simple squamous. You do have a lot of macrophages in this area. Remember, macrophages are those general responders, the big ones that just ooze around and eat bacteria. You have to worry. They ooze around and eat bacteria. They don't care who they come across. They just go and eat them. Right? So you're going to have a lot of macrophages here because you might have some bacteria from your environment. Oh, and you also have lymph nodes, little tiny ones, to help that support of the immune system. Okay, so getting actually to the respiratory membrane. There are 3 types of cells at the membrane between, this is the capillary, so we've zoomed way in. So we just took one little section right here and we're zoomed in on that part of that capillary and part of that air sac. So if you were going to zoom in there, you're just looking at this tiny little spot right there at the tip of my arrow. So when you do that, this is the inside of the capillary with the red blood cells, and then this is the inside of the alveolus. So between there, the oxygen has to come from the air sac of the lung, from the alveolus, into the red blood cells, and the carbon dioxide has to come either from the globulin of the red blood cells or the plasma and get into the alveolus so you can breathe it out. And it's not going to have very long to do that, right? Just however long it's in that capillary. So there's 3 different types of cells here. There's type 1 pneumocytes that are thin, squamous epithelial cells. They form 90% of the surface of the alveolus. So here's the capillary, here's the alveolus, and then this would be a type 1 pneumocyte. Thin, simple squamous epithelium. The type 2 pneumocytes are round to cube-shaped cells that secrete stuff, and they produce a substance called surfactant. So the type 2 cells are right here. Surfactant is a chemical kind of like soap. It makes the surface slippery, but it doesn't make bubbles. And the production, the activity of those type 2 pneumocytes is one of the key indicators of whether a baby is going to survive if it's born early. And so if a mom goes into premature labor, sometimes they'll try to give the mom a shot that circulates through to the baby to try to develop their lungs. Have you heard of that? And what they're trying to encourage is not like the overall size of the lungs, but they're trying to encourage the activity of those type 2 pneumocytes. They don't start being active and producing surfactant until the last few weeks of pregnancy. And the baby has to be able to produce surfactant in order to be able to inflate its lungs properly once it's born. And so that surfactant it lines the inside of the air sacs, and it makes them a lot easier to inflate and deflate. Otherwise, before the baby's born, all those air sacs are collapsed. They've never been filled up with air before. And the very first breath that baby has to take is like blowing up a balloon for the first time. Is that harder? Okay. So you have to line the inside of those air sacs with surfactant, and that makes them a little bit more slippery and able to expand. And then you have dusk cells, which are phagocytes. And so like the macrophages and stuff, they go around and they eat bad guys. The tissue surrounding the alveoli contains those elastic fibers I pointed out on the previous slide, and they contribute to the recoil of the lungs to help you breathe out. Okay, that's air sacs. Oh, we've got time. We usually break at 9:30. I'll continue on. So, guess what? You have 2 lungs. That really shouldn't be a shocker to you. Okay, so you've got 2 lungs. I took the front off of these. They are the main organs of respiration. Really, if this stuff is surprising you right here, we've got some studying to do. The base of the lungs sits on the diaphragm, so unlike the heart, this makes sense. The base is at the bottom. Okay, so the flat surface, the broad surface of the lungs is the base, and those sit right under, so this is the diaphragm here. So the base of the lungs sits on the diaphragm. The apex of the lungs is at the top, so this corner up here is the apex. On the medial surface, where the bronchi and the blood vessels enter the lungs, this space right here between my fingers, remember how on the eyelids you had the palpebral fissure? And it was just the space between the eyelids. Okay, so this area right here, it's kind of the entry and exit point, is kind of the open area where things get in and out of the lungs, whether it's your bronchi or your blood vessels. This open space right here where all the tubes go in and out is called the hilus. So it's not really like a thing to point to, it's more of an empty space. So it's the opening of the lungs where all of the bronchial and blood vessel tubes go in and out. So it's the space between my 2 fingers here is the hilus. So you have one on the left, and you also have one on the right. So I'll pass this around and you can see it later as well. All of the structures in the hilus are called the root of the lung. So again, the hilus is kind of the open area, and the stuff in the hilus is the root. Okay, so I'll pass that around. You can see a little bit better when you can turn it. The right lung has 3 lobes that are separated by fissures or grooves. And the left lung has 2 lobes. Why does the left lung have less lobes than the right lung? Yes, the heart points to the left and takes up some of that space. So there's only enough room for 2 lobes. There is an indentation on the left side where the heart fits in there called the cardiac notch, which you should also be able to see on that model. You can see it on here. See the cardiac notch? Here. Cardiac notch. So these are all things that you should be able to label. Okay, so you might want to make a little note for yourself. for labeling?
Yeah.
Okay. What? The divisions of the lungs are called the lobes. Those are supplied by the secondary bronchi, so that first branching goes to the lobes of the lungs. And then the bronchopulmonary segments are supplied by the tertiary bronchi and separate from one another by connective tissue, which doesn't show up very well on the model. But in this part of the model right here, you can see kind of that spongy nature of the lungs. So I could label lobes, but the lobules don't show up well on the models.
So hilus and hilum are the same thing?
Yes.
Because in the book it's labeled hilum.
Yes, that's the same thing.
You said it's the space between the lungs and where it comes in?
Yeah,
How
so...
did you describe that, sorry.
Yeah, like from here to here, that space is the hilus or hilum. Okay. Or like on here, between my thumbs right there. That's the hilum. And then the actual stuff in there is the root.
Okay.
So labeling, you should worry about lobes, but not lobules. I can't really do that on labeling. They don't show up very well. This picture shows the lobules better, but we're not going to label this comic color picture. We're going to stick with models with all the different things that we put on the test. So on the top picture, you can see the obvious differences between the lobes. So they both have a superior lobe and an inferior lobe. But on the right-hand side, you also have a middle lobe. See that? So they both have superior and inferior, but only the right one has the middle lobe. So then you have the hilus or the hilum, and then the root. This one shows the lobules a little bit better. So you can see the little colored regions. Those are supplied by the different tertiary bronchi. That's more of an issue later on when we come back to our predict question when you're talking about a collapsed lung. Based on how they're broken up like this, you would think that you would have like a whole left lung would just be crumpled and collapsed. Just going to be shriveled and empty? No. It's not like a balloon that you can pop. So if you have a collapsed lung, it's probably not going to be all of the lobes of the whole lung. It's going to be a lobe, or it might even be a lobule that's having problems. Does that make sense? There are a lot of different muscles that help you with respiration. If you are just doing general, everyday, quiet breathing, you're mostly relying on the muscles between your ribs. And so when those contract and relax, it expands and contracts your rib cage, which provides enough of a pressure difference that it allows you to fill and empty your lungs for a normal breath. If you need to do labored breathing, like if you're exercising or trying to catch up with your kids, or you're in lab and I tell you to take a big, huge breath, or at the doctor's office and they say take a deep breath and you really suck it in, then you have some other muscles right here that really pull up on your rib cage and expand the volume of your rib cage to create a greater pressure difference and allow you to take in a deeper breath. When you are breathing out, your abdominal muscles are going to contract and push in, your diaphragm is going to relax, and the volume in your thoracic cavity is going to decrease. And if you go back to physics, how many of you have had physics in the last 5 years? Okay, 2. There is, one of the gas laws is, I don't remember if it was Boyle or Charles, some white guy. This relationship between pressure and volume. Okay, so think about when volume increases, what does pressure do? Decreases. And when volume decreases, pressure increases. And so if you decrease the volume, in the lungs, what's going to happen to the pressure? It's going to increase. So if there's a greater pressure in your lungs than out in the world, the air is going to exit out of your lungs. When the diaphragm contracts, it pulls down. What's that going to do to the volume of your thoracic cavity? It's going to increase the volume, which is going to do what to the pressure? Decrease the pressure, so you're going to have a low pressure in your lungs compared to the outside world. And so really, it's not you, it's weird to think about, it's not really you pulling the air in, it's more like the air pressure in the outside world is greater, and so it's like the atmosphere of the earth is shoving the air into your lungs. It's a push, not a pull. You're creating a relative negative pressure, and so that pressure in the outside air is going to be greater, and that's going to shove the air into your lungs. Weird to think about. It's like the earth is making you breathe. Okay, breathing in and breathing out. Breathing in is inspiration, breathing out is expiration. So when the air exits, you expire. When the air goes in, you inspire. For inspiration, for taking a breath in, that relies on the muscles of your diaphragm, the external intercostals between your ribs, the pectoralis minor, underneath your pectoralis major here, remember it's like a three-fingered muscle, and the scoenies. In the diaphragm, it's dome-shaped with the base of the dome attached to the inner circumference of your ribs. Who has the model? So if you want to pass that model back around, you can take a closer look at the diaphragm and how it's connected. We don't have the ribs in there, but you can still see how it's all connected. In the center of your diaphragm, there's something called the central tendon, which is at the top of the dome. And that's what provides that attachment point in the center, because otherwise there's nothing for it to hold on to. So your diaphragm attaches on the circumference to the inside of your ribs. But in the center of the diaphragm, it has to have that dome shape, right? There's nothing there in the center for it to attach to. There's no bones. So it has a central tendon that's attached right there. When you're just sitting there quietly listening to me breathing, you're breathing. You're not listening to me breathe. That accounts for about 2/3. Those muscles right there account for about 2/3 of the increase in the size of the thoracic volume. Moving that central tendon down and flattening out the dome and your abdominal muscles relaxing. So if your abdominal muscles relax, you create a greater volume in your abdomen, and that pulls down on the volume of your thoracic cage. There are other muscles that we're not going to get into that elevate the ribs, and the costal cartilages allow the lateral rib movement so that you can actually take a bigger breath in to actually forcefully move your ribs. When you breathe out, there are muscles that depress or push down on the ribs and the sternum, and the abdominal muscles and the internal intercostals are going to contract. So if you contract your abdominal muscles, that decreases the volume in your abdomen, which is going to push up on your diaphragm. So really when you want to blow out, you can feel your abdominal muscles tensing up. You can also feel it when you cough. You've had a cough for days and days and days, and your stomach hurts, your abdomen hurts, then you know that you're sick. It's not fun. If you have labored breathing, all of those muscles are active and they contract more forcefully, and the expiration happens more quickly. So they've got a bucket and a water pump here, whatever helps. You think about lifting up the handle of the bucket and pulling up on your first few ribs is going to cause an increase in volume. I don't know if I put a bucket handle there as an example, but your book did. So think about that as an increase in volume. It's like lifting up right there, and it's going to increase the volume that you have in your thoracic cavity. At the same time, your sternum, kind of the manubrium, angles posterior, and the xiphoid process angles anterior, so the whole thing picks up like this. It increases the back to front volume of your chest cavity. The linings of your lungs. These are the pleura. And we talked about membranes. We talked about the heart. We had the epicardium. Remember those? Okay. Your lungs are lined in the same way. And so the same, they're not really prefixes, the same beginning words are going to apply. We have visceral and parietal. Which membrane touches the surface of the organ? Visceral or parietal? Visceral. Visceral is guts. Okay? So the visceral pleura is going to actually attach to the surface of the lung. It's made up of simple squamous epithelium. And then the parietal pleura, parietal is the one that's outside, right? So that one's going to attach to the thoracic wall. And you can have a space between the two of them. That's called the pleural cavity. So remember how cardio was all heart stuff? Pleural is going to be all lung stuff. The pleural fluid acts as a lubricant. That's what fills up that pleural cavity, and it helps hold the two membranes close together so that they can touch one another. If you get an infection between those two, or you get fluid on your lungs, not in your lungs, but on your lungs. Is that one of the ones on the game Operation? Take water off the lungs. I thought that was one of them that you could do. But you can get an infection of the between those two linings, and the doctor might have to draw fluid off of your lungs. Because if you get a buildup of fluid in here, like from an infection, that can interfere with your lungs' capacity to expand and fill up. The mediastinum is the central region, and that contains the contents of the thoracic cavity. So we already talked about the mediastinum when we talked about the heart. So this is the mediastinum, and then you have the pleural cavity. Okay, so this is the connection between the respiratory system and the blood and the lymph supply when you connect the two of those together. There are two sources of blood into the lungs, kind of like there's two sources of blood to the heart. Okay? So when blood comes into the heart to be circulated, it comes in through the vena cava, right? But then you also have to have the blood supply that feeds the heart muscle, right? So your lungs, just like your heart, kind of have a dual job. They're supposed to be oxygenating the blood, but your lungs themselves are living tissues, so they need a blood supply. And so those are the two different sources of blood into the lungs. The pulmonary artery brings the deoxygenated blood to the lungs from the right side of the heart to be oxygenated in those capillary beds. We already saw those pictures. Yes? The oxygenated blood is going to travel to the tissues of the bronchi, to the tissues of the lungs, through the bronchial arteries. So the lungs have their own blood supply that's oxygenated, just like the heart has its own blood supply that's oxygenated. The bronchial arteries are branches off of the thoracic aorta. So there's the blood supply that comes into the heart to be oxygenated, and then there's also the blood supply that comes into the heart to feed the heart oxygen and nutrients. And that comes from the bronchial arteries. Just like any other tissue of your body is going to use up that oxygen, part of it is going to exit through the bronchial veins, and part of it is going to merge with the blood of the alveolar capillaries and return to the left side of the heart. So that's kind of weird. Right? So part of the blood that feeds the heart goes into your normal vein system, and part of the blood that lungs, and part of the blood that feeds the lungs is actually going to get dumped right back into circulation on the left side of your heart, which is the oxygenated side. It's kind of weird. Blood going to the left side of the heart via the pulmonary veins carries primarily oxygenated blood, but also some deoxygenated blood from this supply up here. So that blood that returns back to your heart is mostly oxygenated, but it's got some used up blood as well. That is going to be a good place to stop because it's not quite 9:30, but this is a big shift in what we're going to be talking about. So we're going to talk about some filling in and filling out of the lungs. So let's take a quick break I have 9:17, let's come back at 9:25.